Okay, maybe we start because we are videotaping these lectures, so I think that there are only few and some may come and go and so on from here. But you are very welcome to Finland. Here are some information about Finland as a whole. We have 5.5 million inhabitants here and about 18 persons per square meter. And as you saw when you came here, that there were only few houses that you see. It's so that at the southern part of Finland, we have near the cities about 20 persons per square meter, but in Lapland we have 2 persons per square meter. So we have a plenty of place here, as you see, also at this room. The capital is Helsinki, and the oldest town of Finland is Turku, and in Swedish it's Åbo. And we, as you know, in the history, we have been under Russian and under Sweden. So in Turku there are almost 200 inhabitants, and it's growing all the time. It's one of the cities which is growing all the time. The languages is Finnish and Swedish, but there are also many people from Russian coming to Finland and also from other countries. Religion is most is Lutheran, but there's also Catholic and Orthodox and Islam and so on. Health services and social services are separate in Finland, and there's now a massive reform going on in social and healthcare services, and it's presumed to be ready 2021, and then the services will be combined. But it's a very difficult reforming. And through this reform, for example, for handicapped people, the personal budget will be taken. Well, in Finland, people pay a lot of taxes from salary. It can be, for example, me, I pay taxes about 36% from my salary. And the taxes are going to state, municipalities, welcome, and for church. And healthcare and social care services are paid by municipalities now. And we have 311 municipalities in Finland. And as you know, that municipalities everyone have different economical situation, so the services are not equal for everyone. For example, it can be said that this area where we are now, it's quite rich area, combined, for example, to eastern part of Finland. So our administration has thought that there are too much municipalities and too much differences between the services. So the reform will make this better. So there will be 18 provinces which will be responsible arranging services in social and healthcare sector in the future. So this is Finland, and we have special centers, like almost like this. They differ a little bit in every red point in this map. And as you see that we are here in this point, and this point is for person who speaks Swedish. And the name of this place is in Finland KTO, and in England the Support and Expert Center, SEC. And what's that SEC? It's a service center for special welfare district of southwestern Finland. And our area is now over 500,000 inhabitants. We are gathering that area. And in this place, here we have 72 inpatient care for crisis, rehabilitation, and for examination of patients. But nobody is staying in this place. And psychiatric patients we have here 20. And neuropsychiatric patients we have almost 40. And different services for children and for adults. We have also 18 different kind of group homes, including 250 individual homes. And I will show you a video of working here in this place and working in group homes. In this place we have specialists, neurologists, psychiatrists, pediatrics, psychologists, social workers, speech therapists, occupational therapists, physiotherapists, communication therapists, nurses, advisors, dentists, laboratory workers, pharmacists, etc. Together about 700 workers. And I have been 10 years the director of this place. Our budget is 33 million per year. And if you think that how much the municipality is paying, for example, if the person is in this place as an inpatient, it's about 700, a little bit over 700 euros per day it costs. So quite expensive. So you saw the piece of the topics why we are here today. And now I will present Roger Pangs. Can we say the guru of guru?
Well, you can say it.
Yeah.
Sure.
But would you please present yourself, where you are from and what you are doing and what's the master class and what's the board and so on?
Yep, kiitos paljon. Hyvää iltapäivää. And that's as far as I get with Finnish. So. Thank you very much for being here. I'm Roger Banks. I'm a psychiatrist for people with intellectual disability and autism from the United Kingdom. and I currently work with NHS England in the National Learning Disability team, and I have been a member of the European Association of Mental Health and Intellectual Disability for some years, and I'm currently president. The European Association was formed over 20 years ago with the ambition of trying to increase awareness and skills and understanding in various European countries around the mental health needs of people with intellectual disabilities. It was formed at a time when there was a push towards deinstitutionalisation and normalisation, quite rightly, but a concern that there wasn't the matching expertise and knowledge in communities and clinicians and others to be able to support the mental health needs of the people who were going to live in those communities. And the association over the years has brought together a wide range of colleagues from not just across Europe but also into Australia and America as well, usually through congresses that are held every 2 years. Recently we have tried to see how we can meet the aims of the organisation a bit more widely than just having congresses. And the idea of having masterclasses was born. We had our first one in Zagreb earlier in the year, and this is the second. And the idea is to try and meet and talk with people who are working in the same field and to share our experience, our ideas, our thoughts, knowledge. And this is the first masterclass that we have videoed. Our hope is that not only will you have the video to be able to distribute amongst colleagues elsewhere in Finland, but then we can also start to build up a resource on the association website that people will be able to access. The challenge is that the people who really need support and help and advice usually cannot afford to come to expensive congresses in Barcelona next year or in other places. So we need to find ways of also speaking to people elsewhere. So this is part of that challenge, and thank you for hosting this, and thank you to Saya and colleagues for setting this up and videoing it. So there are a number of presentations this afternoon by colleagues from the board. We have also indicated people who might be respondents, so one of us might just make a comment at the end of a colleague's presentation to highlight particular points. We would like to try to make sure there's enough conversation, so I will frown at people when they're talking for too long so that we'll have time to actually talk all together. So, Kiitos. I think, Ken, are you first up? Okay, so my colleague Ken Courtney, who works as a psychiatrist in London and has just been elected as chair of the Faculty of Intellectual Disability within the Royal College of Psychiatrists in London. And Ken is the honorary secretary for the association, and Ken's going to talk about services in community.
Okay, good afternoon everybody, and thank you very much for the invitation to present today. As Roger said, I'm working as a consultant psychiatrist in ID in London. I'll explain more as I go through the presentation. So what I really want to present to you today is just on community services as opposed to inpatient services, and really to just present what we're doing in London for you to have an opportunity to think and really to compare with what's happening in your own areas. I have to say I'm just presenting this is what we're doing. I'm not saying this is a perfect model, and I'm certainly not saying that this is one that we need to adopt wherever you are, but it is, hopefully we'll actually just get a discussion around community services and what they can achieve. So what I'm going to talk today about is just the community services, what actually goes on in the services themselves, and also to describe some of the care pathways which we have in my own service. And also at the end, of course, you wouldn't be able to finish off a presentation without talking about the challenges, otherwise known as the problems that you have. So we work our way towards those and maybe understand why they have arisen. So let's go back a little. We've called it institutional care or hospitals, and just an example of one of the hospitals in Hertfordshire, which is outside London. These were common during the Victorian times, the 1800s, and for nearly about 150 years, 180 years in fact, you would have hospitals, asylums, dotted around metropolitan urban areas, where people with intellectual disabilities and those with mental health problems went to live away from the urban areas, of course. It all came with industrialisation. And the last ones we managed to close in the early 90s. I started training in the late 80s, and I was really quite surprised that actually I started my training in these institutions, ID institutions in the UK. So I was very much at the tail end of things, and I began to witness what they were like. But at that stage they were closing, and often they were closing because of scandals that had occurred in the care that people received. So that's how it used to be. Now let's look at what we have now. ID services, what I've listed here on the right hand side are all the policies that have come out of governments since the 1980s, and I'm sure you all have policies in your countries about how things are going to be. So we've come right through to 2012, and policies on how community services should be developed, how they should be constructed, inpatient services, what should happen to them and how specialists they should be. Living in the community is very important, and again we've got policies around that. And then moving on to mental health services. Interestingly, the whole mental health aspect of living in the community came later. The ones I really want to point out to you is Mansell report in '93, which had to be repeated again in 2007. And then there are these ones, Death by Indifferent in 6 Lives and Healthcare for All. These ones really hit the headlines when particularly the 6 Lives report, where they described how 6 people with intellectual disabilities in acute hospitals were treated and how they died. And that was really quite a wake-up call for the system in the UK. And that led on to a document called Healthcare for All, which I do believe has actually made a big change to how people's physical health is actually viewed and cared for. And lots of things have fallen out from this. But unfortunately, not everything was perfect then, and didn't continue to be perfect as a result of that. And that's how we've ended up with these documents, again, building the right support, which is around community services. And you'll understand a bit more of that as I go on. So I just wanted to give you an example of one thing, which is this service model specification, which was produced for commissioners, people who buy services in the UK. The specifications are never prescriptive in that they don't tell you exactly what you should be doing, but often leave it up to local providers, local services to decide what they want to provide in the community. So I've listed at the top there integrated teams and then followed by health-only teams. So I'm now talking about community services and how they're configuring the teams that are working together. Now, an integrated team will be a combined team between health workers and social care workers, something that Saya mentioned earlier on. And as well as that, though, we also have health-only teams. So nationally, you will have a mix of service configurations in the country. So in some ways, what I'm saying is that no one size fits all, and often it's down to the local area to decide what they want. Let's move on to ID services. So I've just broken them up into adult ID services and children's ID services. The one other major group which is missing from this, I won't make much reference to them, are the offenders, because they have their own special types of services as well, but also they interface with community services too. So this is a general map of London with all 33 boroughs in the city. I work up in Haringey, which is towards the north of the city there, and I work in an integrated service, so the members of the team come from social care and health care, so it's a joint service. And this is relatively common in London, that you will have integrated services. However, when you go outside London, you don't always get integrated services. The norm actually is to have separate social care and healthcare services. And this is interesting because when you work in London, and if you've trained in London, you just believe that this is the model that applies nationally, but this isn't always the case. Children's services, on the other hand, where I work, and again it's true for a lot of boroughs in London, tend not to be integrated. They tend to have separate streams of mental health, physical health, education and social care. So you have nearly 4 groups of people working with the same families and the same groups, and they communicate with each other, but they don't, and they work with each other, but they're not managed under the same operation. So that's that. Now, what are we talking about in terms of community teams? I've listed here the members of the community team that we have, which would be common to the teams in other parts of London, and really mirrors exactly what Saya was mentioning earlier, the members of the team. And the main thing, though, however, in my service and in most of the services, community services in London, is that they are community-based, so we're not actually sitting on the hospital site. And in fact, most services have access to inpatient beds, but they don't manage the inpatient beds. So examples of some of the staff in the community, that's the High Road in Haringey. And these are 2 members of the team. Heather is a nurse in the service, and Lorraine is a speech therapist, just demonstrating how wonderful it is and how joyful it is to be working in the community. These are the services that we actually provide. So there's a good range of stuff between social care and healthcare. So I'm very much involved in the mental health aspect of providing care. The nurses will be doing both mental health and physical health, physiotherapists, speech therapists as well. I mentioned the day opportunities. It's really how we actually give and provide meaningful activities for people during the day. And the team also provides a lot of support around accommodation. I'll speak about that in a bit more in depth. The other parts of it which we do provide, but they are important, but they're not as great, would be hospital liaison, because we work with a nurse who works in the acute hospital and who makes a lot of contact between our service and the hospital teams. And I mentioned the intensive support team as well, and care support. So there are the various types of services that we provide. But what about the activities, which is the most important part? You can have the team set up, but what are they actually doing? So I've listed some of the things that we are actually doing. So you can have a lot of advice being given and signposting. Direct interventions, that is what the psychologists, psychiatrists will be doing. Speech therapists will be doing when they're managing a person's swallowing problems. Physiotherapists as well. We manage hospital admission. We don't have beds, so when people need to go into hospital, we have to manage that admission, meaning I need to be in touch with the staff in the hospital around the care that the person is managing in order to get them out as soon as we can, rather than they being left in the hospital. We provide respite care as well, and then all of these other areas. One point which is really important for us these days is professional training. So we will have students in psychology, trainees in psychiatry, occupational therapy. All of the students will come through our staff, come through our teams because of our links with the universities and training schools. Really, really important in order to get the next generation coming in to work in the service. We've got real problems with recruitment, and that's why I emphasise this, is in order to keep the service going over the next 10, 20 years, we really need to be training people up to it. And we do quite a bit of quality improvement, and we are engaged in research work in the universities. But that's one of the advantages of being in a London service. It doesn't always apply to services in rural areas. And I mentioned there specifically transitions from children to adult services, a very challenging process in any service as well. So there's some of the activities we actually engaged in. So this is my local service. The borough has a population 271,000, which is probably bigger than Turku, I assume. Yep. Okay, so you'd expect the prevalence to be greater than 4,000 ID in the borough of Haringey. However, there's only just over 700 who are receiving a service from us. So therefore, the majority of people are using mainstream services. And on our mental health caseload, we're looking at just over 200 people. Okay. Accommodation is really important. Lovely photograph from a local estate agent. This is the type of accommodation that we're actually dealing with. It's these Victorian terrace houses right throughout the borough, and this is where people are living. And some of the most challenging people are living in this type of accommodation, which you can imagine can be really difficult if you've got autism and sensory problems, and if you have to live with other people as well against your own choice. And that's why we get referrals for challenging behaviour, largely because of the accommodation, I believe. But people are living in a range of provisions, so they can live with families, and that's often where they start up until the mid-20s and maybe into their 30s. And especially among immigrant families, they tend to stay with the families for longer. Some will have their own tenancy, and a lot of the people we'll be working with will be living in what we call supported living. So they will have input from care staff, and it can be anything from 4 hours a day or less up to 24 hours a day, because we've moved away from residential care. So residential care was for 24-hour day care. But now we've gone to supported living, and there are reasons for that, financial reasons for that. And then the last one I wanted to mention was Shared Lives, which is quite an innovative service, best described as adult fostering. So you understand how children are fostered into families. Through Shared Lives, adults will actually go and live with families for many, many years. And in fact, you can see people moving through this type of accommodation as they grow older. And sometimes if their needs are greater, they will move into Shared Lives. Or young people, as they're coming out of family home, may need that extra support through Shared Lives before they move on into maybe their own tenancy. So just need to get back to the official stuff, service providers and regulators. So our services, our NHS services, the health services and the local authority services are statutory services, which are regulated by the Care Quality Commission, who inspect the services usually every 3 years, and will give you a rating on how your service is doing. So just checking on the quality that is being provided. A lot of the providers will be in the independent sector or private sector, and that will be the social care providers in the sense of those who are providing accommodation to people. So we're working a lot with independent providers who are giving homes to people, because our own services do not provide homes to people, if you understand, but we'll commission it. And of course we're always acting within the constraints of the Mental Health Act, when people are admitted or in the community. Mental Capacity Act in particular, a very influential, a very good piece of legislation, really, governing how we care for people, both the independent providers but also in the statutory agencies. And then I just mentioned the Care Act and the Autism Act. So what are the eligibility criteria for our service? So we work only with adults 18 years of age and above. So we're not a lifespan service, just with adults. They need to have an intellectual disability, and then they need to have a need as defined under the Care Act. I'm not going to explain the Care Act to you because it's not the easiest thing to understand. But partly because of the way things are going economically, we're really just working with people who are eligible for Care Act. They need to be resident in the borough. and they need to be registered with a local GP. So if they tick all those boxes, then we'll be able to work with them. Now, the care pathways. We've developed these in the service, and we've got two main ones, mental health and physical health. And under the mental health ones, it's a way of us understanding how we're working with people and how we're managing people and helping to support people. The greatest number of them, in fact, will be those with a mental disorder. I'll explain a bit more later. So the psychiatrists, psychologists and nurses will be working with this group of people. But we also have separate pathways for dementia, autism and ADHD. So when somebody comes into the service, they're assigned to one of these pathways depending on their need. And then while we are working with them, they could be under 2 or 3 pathways. So you've got autism and you're developing a mental disorder, it would be managed under 2 pathways, but for different difficulties. Physical health one I was just mentioned there. So a lot of it is long-term conditions in physical health pathway, and then just the others I've mentioned, which are very important, particularly the swallowing one. That's one of the more acute assessments that we actually do within the service. So this is just some data I've cobbled together from our own service. So this is going back to the 212 people we have. So you can just see the breakdown there in terms of the category of intellectual disability. So most of the people we'll be working with would have mild or a moderate intellectual disability. There are quite a significant number who have a severe intellectual disability, and why they are significant is because they use up a lot of resources in order to support them. And from a psychiatrist's point of view, it's often around medication and helping to manage the medication. So I've given you some figures around those with neurodevelopmental disorders. So quite a number with autism there. The mental health one is interesting in terms of the diagnoses. So we've got psychotic disorders there, mood disorders, anxiety disorders, and personality difficulties, along with the organic diagnoses. So the organic ones will be those who have a diagnosis of dementia. Most people will have either psychotic disorder or mood disorder, and anxiety as well, and often a crossover between the two. To be perfectly honest, we tend not to give people diagnoses of personality disorder, but rather having to manage their behaviours in a different framework. But it's helpful if you're communicating with other psychiatrists. In terms of our admissions over the years, our numbers are low. And when I first started over 12 years ago, the admissions were between 15 and 20 a year. But we've managed to actually get the numbers down to single figures. What I haven't broken the numbers down to is those who are admitted to specialist ID services and those who are admitted to general psychiatric services. And the discharges in terms of from the caseload is low, because we have a tendency to hold on to people, but we could actually be discharging a lot more people as time goes on. In terms of governance, I just needed to mention this when you're talking about a community service and managing a team. So people will be assessed for eligibility by psychologists. That's at the entry point into the service. And then they will obviously be allocated depending on what their need is to the multidisciplinary team. We have structures in place in terms of ensuring quality in the service there, which is important for you to know exactly what the service is doing and how you're performing. I'm going to now move on to this, because I do think that nowadays I really can't talk about community services without mentioning the difficulties we've had over the years. And I mentioned scandals earlier on, which we all thought were confined to history. But this one happened in 2012, and it led to the development of the Transforming Care programme. So in England and Wales, we're talking a lot about transforming care, which is in response to this programme on the BBC back in 2011 in this hospital in Winterbourne View. These are some of the still shots which demonstrated the level and type of abuse that people were subjected to in this private hospital. this is the private hospital. So it's not an old institution that I gave you earlier on, a Victorian one. This is a very modern type of hospital, type of building, where this type of care was being provided. Okay, this is Transforming Care programme, and lots of reports, I refer to them as a suite of reports, have come out. This, for me, is one of the more effective, inspirational ones, building the right support, and it has provided a service model around what we should be doing in terms of providing community services to people. It also makes reference to assessment and treatment units, otherwise known as inpatient services, that people go into for assessment and for treatment. The Winterbourne View Hospital was an assessment and treatment unit in the private sector. So what has been happening is a lot more scrutiny has been paid to inpatient services, to these assessment and treatment units, and basically they've had to up their game, get their act together and start improving what they're doing in order to get people out of hospital, because a lot of people were spending a lot of time in hospital without any prospect of going anywhere. The discharge programme from 2012 has been to discharge 3,000 people in the ATUs, just over 3,000 people, halve it by 50% down to 1,500 by next year. That's right, 2019, yeah. So we're not on track to achieve that number, unfortunately, but the numbers are going down. And
15%.
Sorry,
15% is the
anyway, I can't be pessimistic about it, because actually we've had quite a number of notable successes, which has been great. So anyway, let's get on to the challenges in the service that I work in. It is a diverse population, which is unlike other services in the rest of the country. Typical for London, but not what you would get outside London. Neurodevelopmental disorders, we estimate there's probably 30% or so of the ones that people we are seeing will have a neurodevelopmental disorder. To the point now that everyone has an assessment for a neurodevelopmental disorder when they come into the service. Very, very important, because if you've got a neurodevelopmental disorder, what we have found is that you're more likely to end up in an inpatient service at some point in your life. Obviously the people are very complex in the presentation of the ones who I would see. And safeguarding is very important to us. We don't always get it right, and safeguarding means really just looking after vulnerable adults and making sure that they don't come to any harm, as we saw there in Winterbourne View. It does happen, it continues to happen in the community, but we need to be alert to what is actually happening, and to be, I suppose, to have a nose for it, as you would say, when you're going out and meeting people into their homes. The other challenge, of course, is money. So we've been living under austerity since 2010. So how do we continue to support people in the community, particularly when packages of care are costing around £2,500 a week? This is a number of people, it isn't everybody, but it's not unusual to have these packages of care. The most expensive one we've ever had was £6,000 a week. So there are private providers out there who are earning quite a bit of money from the packages of care. The other challenge, as I mentioned earlier, is staff recruitment, especially among nurses. I don't know if it's the same for you, but it really is at a crucial stage for us in the UK. The quality of the private providers, because you're not always guaranteed that you're going to get quality, even though you're spending a lot of money on packages of care. And also admission avoidance, which means trying to prevent admissions to hospitals, whether it's the acute hospitals or to the specialist ID hospitals. And this is where I'm very much involved, and the intensive support team can be involved as well to avoid people going into hospital. And under Transforming Care, the system of care and treatment reviews have been developed. And they have been a very useful tool in actually bringing together all the community staff who are working with the person, families included and carers as well, seeing is there something else we can do besides people going into hospital. And why it has been effective is because other solutions have been proposed and have actually worked. For example, people going into respite care or people being placed in emergency supported care, while we will continue to work with them in the community. Another challenge, of course, is legislation, and there are proposed changes to the Mental Health Act coming up in England and Wales, so we'll have to work under those when the time comes. And at the moment, under Transforming Care, the NHS is developing a 10-year plan, so we're making contributions into how that will be. And the purpose of that is to propose design services for the coming 10 years. So that's quite an ambitious plan, and it's a real opportunity for us in community services to do a lot more blue sky thinking, as it were. So thank you very much for your attention.
So thanks. I'll try to make sort of the response brief. Thanks for a very lively, comprehensive kind of view of what it is to be a psychiatrist working in the UK and in London and working in this field. If I can just pick out some themes from that. Because we're talking about people's lives, and Ken started at the beginning about talking about children, young people's, or children, adolescent mental health services and adult mental health services. We've always been aware that we need to have a lifelong perspective on people. And the reality is that the way services are delivered isn't done in a lifelong way. It is quite separate. We have these periods of transition, as people call it. It's usually a euphemism for chaos and lack of resources and people trying to shove responsibility back and forth, and people like to call it transition. But we still struggle, and I'm speaking with my NHS England hat on, I guess, now. We still struggle to try to get this integrated lifelong approach, and particularly early intervention. It feels like the system is loaded much more towards the point at which people have a crisis, and usually later on in life. And what we need to do with all the new investment is to think about front-loading the system. So how do we actually work with parents, children, right at the outset? How do we actually prepare for potential behavioural challenges before they occur? So that is an ongoing challenge. I think within there's also implicitly the constant challenge about, should we be talking about specialist services? Should we be talking about mainstream services? Can we genuinely expect to provide comprehensive, high quality, technologically up-to-date, evidence-based services for every single person who has an IQ less than 70? To what extent should we actually, is our job, and often it is our job, to enable people's access to other services, to support them to get the same kind of healthcare and quality healthcare, actually sometimes better quality healthcare than the general population. So again, that's a tension. Ken referred to the Transforming Care programme. We can't think about working in communities without thinking about, well, why are we talking about working in communities? Because people have been in hospitals and people remain in hospitals. And as you rightly said, in 2014 there were about 3,500 people with intellectual disabilities living in hospitals. Many have been there longer than 5 years. There are people that we have seen through care and treatment reviews who've been there 35 years, 40 years, and they're in hospitals. So what is this treatment that people are having that takes 45 years to deliver? Big questions then about needing to move people on and move people out. And of those 3,500 people in 2014, around about 2,400 had no identified date of discharge. The planning wasn't in there to think about that. So the big challenge is not just about cutting down the number of beds and moving people out. What does it take to actually support people in the community, like your patient? People who have mental health problems, people who present behavioural challenges, what does it actually take to do that? And we rely very heavily on the capabilities, the competence of providers, care providers, of staff, of people's ability to form personal relationships, of people's ability to stick with people when the going gets tough. And that can be very tough. And so resilience in carers is really important. And a lot of our time is really spent in supporting, nurturing, sticking with carers and being able to provide crisis support so that they can stay with the person and continue to support them. The final thing is the interface. When we think, so we're not just talking about mental health, we're talking about people's general health and well-being. And we know that there are a lot of significant health problems in our population, and we also know that they don't get good health care, they don't get treated for common conditions. We know that there are people die younger because you have a learning disability, intellectual disability. You die younger than the rest of the population. How do we address those things? And how do we think about, if we're talking about working with social care, the social determinants of health? So we know that the housing that you live in, poverty, family circumstances, environment, pollution, all those things have an impact on your physical and your mental well-being. We know about the long-term consequences of childhood neglect and poverty and dysfunction in families from children at an early age. So together with our social colleagues, if we're addressing mental health, we have to think about those wider determinants of good health. So those are my comments. I don't know how we're doing for timing. We're probably way over time, but
yes.
Yeah, okay. So there's no questions. We'll take one. We'll take a question while Janneline is getting this up prepared.
Panel discussion at the end.
Oh, there's a panel discussion at the end. Is everybody happy to wait until then? Does anybody have a burning question now? Okay. Great. Thanks.